members of BAUS for giving Department of Urology, Bangabandhu Sheikh Mujib Medical University the opportunity to showcase our hospitality by selecting us as the venue of choice. In this regard, my department also grateful to BSMMU authority for giving permission to use this hall. The month of August is a month of mourning of our nation as it commemorates the tragic death of our father, Bangabandhu Sheikh Mujibur Rahman. He was a visionary and hoped to build a Bangladesh budding with aspiring students with high ambitions to bring out about changes just like himself. At the end of this course, I expect the residents to not only absorb and advance knowledge on urology, a subject that is undergoing constant breakthrough innovations, changes, but also erudite their learning at an international platform. In conclusion, we hope to select few talented residents, young urologists, by evaluating their performance in the exam held at the end of third day's session. The highest score bearers will get the opportunity to attend the annual conference of Urological Society of India to be held in January 2020 in Kochi as a medium to further motivate them and boost their edification. Although the session is targeted for the residents, I believe that this would also to be a great learning curve for us in light of exchanging our views through effective communicative interaction. I am pleased to see a huge crowd today and grateful to the people attending considering the inhibition put on their leave for the sake of an increased task force in combating the epidemic of dengue hitting our metropolitan. I hope the BAUS AOA Lessons in Urology course 2019 cultivates to be a successful one. Again, thank you all for patiently lending me your ears. May Allah bless you all. Thank you.
Thank you, Professor A.K.M. Khurshid Alam sir. Now I would like to request Dr. Sudip Dashgupta, Scientific Secretary of BAUS, to say about introductory speech about this lessons course. Dr. Sudip Dashgupta.
Good morning. Thank you, Professor Shafiqul Alam Choudhury, Secretary General, Bangladesh Association of Urological Surgeons, to invite me. Respected Chairperson of the session, Professor Kaji Rafiqul Abedin, President, Bangladesh Association of Urological Surgeons, and all the distinguished persons present in the days, and respected members of Bangladesh Association of Urological Surgeons. American Urological Association is a premier urological association which provides a valuable support to the urological community. The mission of the association to promote the highest standard of urological clinical service through education, research, and formulation of health policy. And AUA lesson course actually is a program to motivate and improve the standard of the residents. And this association was founded in 1902, and since then, this association is conducting different programs in different names in Japan, Australia, Brazil, Argentina, Mexico, and different cities of Central America. Next to India, for the last 5 years, since 2015, Bangladesh Association of Urological Surgeons, with the collaboration of American Urological Associations, the BAUS AUA Lessons in Urological course is being held in our country. And we are very much happy that for this session, our residents are being exposed to the different urological services to urological care. And this time, this year, August 19 and to 21, we have the lessons course. As a scientific secretary of this organization, I welcome all of you and to actively participate these sessions and to make it successful. Thank you very much.
Thank you, Dr. Sudip Dashgupta. I would like to request Chairman, Scientific Subcommittee, Professor A.K.M. Jamanul Islam Bhuiya sir, to introduce foreign faculties. Professor A.K.M. Jamanul Islam Bhuiya.
Mr. President, Professor Kazi Rafiqul Abidin, Chief Guest, Professor Kanak Kanti Borua, Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, all dignitaries in the dais, my respected teachers in front, and learned audience, ladies and gentlemen, very good morning. It is indeed a great pleasure for me to introduce the foreign faculties before you. The BAUS and AOA lesson course is starting. You have already known that it is the 5th program that is going on from today. It is although it is the program is for the residents, I think residents will learn, and it will be the revision class for the seniors, although it will be the teaching class for the residents, and all of us will be benefited by this course. So I first call upon the name Charles Powell. I will request him to stand up. Everybody will see you. Charles Powell, he's from America. He is the foreign faculty today. Akhil Das, he is also our foreign faculty. You will, all of them, you will get the biodata and you will everything during their speech. You will learn everything about them. Chandra Sundaram, Muhammad S. Chaudhuri, he is not foreign faculty. He is the, I will call him that he is the son of this soil. He is our elder brother. He is our teacher. He is everything for this course. And he is the key man who has done the memorandum between the AUA and the BAUS. And under his guidance, this program is going on. Motahar Ahmed, he is also a good friend of ours. Although he is not here, he will come very soon. He is a very gentleman, very lovely man, and energetic man. We are being grateful to him because we are very much benefited, particularly in robotic surgery, laparoscopic surgery, although we have got not robot till now. So my heartiest thanks to Professor Konokanti Bor also, as he has come here, and he will encourage these. His presence will encourage us and also the residents to go on far. Thank you very much.
Thank you, Professor Jamanul Islam Bhuiya, sir. Now I'd like to request such a person on behalf of foreign faculties who is the mentor, who is our mentor, son of this soil, Professor Muhammad S. Chaudhuri, sir, and who acted as bridge between Bangladesh Association of Urological Surgeons and American Urological Surgeons. He is actually, we don't treat him as foreign faculty. He is our brother. He is everything of us. Thank you all. Professor Muhammad S. Chaudhuri.
Thank you, gentlemen. Okay, well, good morning. I was asked to say a few words on behalf of the foreign faculty, and I'm truly delighted to do so. Let me start by acknowledging Dr. Kanakanti Borwa. He's a neurosurgeon by training, but I think he loves urology. So we welcome him to the dais. Thank you, Dr. Borwa. I also want to acknowledge the president of Bangladesh Association of Urological Surgeons, Dr. Rafiqul Abidin. He is in the dais. The Secretary General of Bangladesh Association of Urological Surgeons, Dr. Shafiqul Alam Chowdhury. I want to say a hearty welcome to all of the members of BAUS. And most importantly, I think this course is really for the residents, although I think everyone will benefit from this one, but this course is for the residents. And I hope you, all of the residents, get as much out of these next 2-day courses as possible. And I also want to send a loud shout out to Dr. Ishtiaq Ahmad, who is the scientific secretary for this conference and who has put together an outstanding conference for the next 2 days. On behalf of the faculty, I want to thank all of you for inviting us to this really very important conference in there. I also want to take this opportunity to thank really American Urological Association, they have gone out of their way to support this program for the last 5 years. And I think both sides, both the AUA as well as the BAUS, has benefited from this cooperation between the two groups, really. I really want to say thank you to John Denstedt, who was here as a faculty 2 years ago. I want to say thank you to Asim Shukla, who is the international secretary, who really was instrumental, really, even in supporting this program. And they are really great friends of both of these associations, and I want to thank both of them, really, for that. I hope Dr. Chandra Sundaram, he is a member of the board of directors, and we spoke this morning, that hopefully he will take the best words, that this collaboration between BAUS and AUA is working out really well, and I think we should continue and pursue this further as we go along. I think I especially will urge the residents to take full advantage of this course over the next 2 days in this one. You really have 3 outstanding faculty in front of you, and these people are really experts in their field. And all of the residents can interact with them over the next 2 days, hopefully get as much out of them as possible in there. And I urge the residents that there are a lot of resources which AUA provides, and you guys are entitled to this as members, especially regarding the AUA University as well as the core curriculum, and both of these you guys should be able to use and get as much out as possible, both to increase not only your knowledge base as well as your technical skills over the next few days. What I'd like to do, just say a few words about the 3 faculty who are here. Let me start with Chandra Sundaram. I had the privilege of working with Dr. Sundaram in the American Board of Urology Board of Directors. We worked together for 2 years till my term was finished. I believe, Chandra, this is your last year of the term. And I'll tell you, Dr. Sundaram is not only an outstanding urologist, he is a world authority in minimally invasive surgery as well as in robotic and laparoscopy. But he's a wonderful human being and a great colleague. Chandra, thank you for coming. You know, I knew very little about Dr. Charles Powell till I met him yesterday, and I'll tell you, I met him and I thought he's a great guy, really. I just talked to him not too long, just maybe half an hour. And as I was talking to Dr. Sundaram, he puts a lot of his own time in really helping people throughout the world, especially in the continent of Africa. Really, it takes a special man to do it, Charlie, really. And thank you for being in here, this one. Thank you. I want to say a few words about my good friend, Akhil Das. Akhil finished his residency at Jefferson, and he's one of the very few guys who went across all the way to New Zealand to do a fellowship. When he came back, he was the foremost expert in the field of holmium laser TURP, which he still does. And I'll tell you, he is I think he's the foremost authority in the United States in that field. I had the opportunity of working with him for 2 years, between 1998 and 2000. And I'll tell you, I still follow some of the patients. He had done holmium laser TURP in 1998. And these patients have been doing long-term follow-up boss. There are not too many. They are doing great. Akhil, you are the best. And I consider him a personal friend, as always, this one. Thank you. Dr. Mutar Ahmed is not here, but I got to tell a few things about Dr. Ahmed. Dr. Ahmed went to school at University of Syracuse and did his training right there. I'll tell you, he is one of in my book, he's one of the best robotic laparoscopic surgeon in Northeast. And believe me, that's a very crowded field. That's a very crowded field in Northeast, and I really think he is an outstanding robotic laparoscopic surgeon. And what he has done over the past almost 10 years, he comes here every year, and he does a lot of these hands-on courses. And doing hands-on courses, believe me, is not easy in this part of the world. And he works with whatever he got in here. You know what I mean? You can't ask for everything. Not everything is here. But despite the limitation, I think he has taught laparoscopic surgery to many of the people in here, and I think he has raised the standard of urology in this country really to a higher degree. I want to thank all of you really for being in here. And thank you again, and hopefully we'll have a great 2 days. Again, I'll urge the residents to make best use of the next 2 days and use all the resources AUA has to offer. AUA would love to have your comments on this, and I think this association between AUA and BAUS is going to last a very long time because it benefits both of us. Thank you again.
Thank you, Professor Mohammad S. Chaudhary sir, for nice speech. And he is actually our mentor, and he is the life member of BAUS also. I would like to congratulate all the foreign faculties to be here for this program, and all other participants and all our delegates, and especially residents. Actually, for those who this program has been designed. Now it's the long awaiting time to hear from our chief guest of this session, our Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, our mentor, Professor Kanok Kanti Borua sir, who is all time he supports us and he is always with us. Professor Kanok Kanti Borua sir.
Honorable President of Bangladesh Association of Urological Surgeons, Professor Qazi Rafiqul Abidin, sitting in the dais, Professor Chaudhary, a renowned urological surgeon. He is the chairman of the Department of New York University Medical Center, as well as he is the honorary professor of Urology Department of Bangabandhu Sheikh Mujib Medical University. Sitting in the dais, Professor Khurshid Alam, the chairman of the Department of Urological Surgery, Bangabandhu Sheikh Mujib Medical University, and Professor Jamanul Islam Bhuiya, Professor Ishtiaq, and Professor Shamim, and sitting in front of me, the luminaries in the field of urological surgery from home and abroad, and residents, young surgeons, urological surgeons, ladies and gentlemen, very, very good morning to you all. I am very much pleased to be present among the luminaries of urological surgeons from home and abroad here. I am very much grateful to the urological surgeons from USA, especially Professor Chandru Sundaram, Professor Mohammad S. Chaudhary, Professor Charles Powell, Professor Akhil Das, and Professor Mutahar Ahmed. All of them has taken travels to come to Bangladesh to teach our residents, as well as I think from this course also young surgeons will also get benefit. What Professor Chaudhary has said regarding the residents to make best use of time, about the resources, what they will provide you during these 2 days courses. And definitely this will enhance not only the knowledge, but it will enhance the skills. They are the world-renowned urological surgeons, and they are in our doorsteps. And it is the best opportunity to make best use of time, and I hope all these sessions will be interactive. Otherwise, it will not be benefited. So I'll request the residents to be present from starting to the ending of the course. And I hope this will be a wonderful course and it will contribute to increase the knowledge and skills of our residents and young surgeons. I am again extending my heartfelt gratitude to the foreign faculties to come in the campus of this university, and it is my proud privilege to have them among us. At the same time, I am extending my heartfelt gratitude to Professor Chaudhuri, as he is very much keen to improve the urological surgeons, the skill of the urological surgeons, as well as to knowledge of the urological surgeons. As such, the standard of the urological services in this country will improve. And I am again extending my heartfelt gratitude to him as well as the foreign faculties. Thank you for inviting me. I hope this will be a wonderful sessions. Thank you very much.
Thank you, Professor Konokanti Borua sir, for his address as chief guest. Now I would like to thank the authorities of Bangabandhu Sheikh Mujib Medical University, especially our Honorable Vice Chancellor sir, Professor Konokanti Borua sir, and special thanks to the Chairman, Department of Urology, Bangabandhu Sheikh Mujib Medical University, Professor A.K.M. Khurshidul Alam, without whose help this program was not possible. I would like to thank all of them for organizing this program. Now it's the time for the chairman of this session, our Honorable President of Bangladesh Association of Urological Surgeons, Professor Kazi Rafiqul Abidin. I would like to request Professor Kazi Rafiqul Abidin to speak as chairperson of this session. Professor Kazi Rafiqul Abidin.
সম্মানিত urologist বৃন্দ, honorable faculties from home and abroad, বঙ্গবন্ধু শেখ মুজিব মেডিকেল বিশ্ববিদ্যালয়ের সম্মানিত উপাচার্য অধ্যাপক কনককান্তি বড়ুয়া, এখানে উপস্থিত বাংলাদেশ ইউরোলজি অ্যাসোসিয়েশনের সায়েন্টিফিক সাব কমিটির সম্মানিত সভাপতি প্রফেসর জামাল ইসলাম ভুইয়া, আছেন আরও বঙ্গবন্ধু শেখ মুজিব বিশ্ববিদ্যালয়ের ইউরোলজি বিভাগের বিভাগীয় চেয়ারম্যান অধ্যাপক খুরশিদ আলম, অধ্যাপক ইশতিয়াক আহমেদ, সামনে উপবিষ্ট আমার শিক্ষক প্রফেসর এম এস সালাম, প্রফেসর A.K.M. আনোয়ারুল ইসলাম সহ আমি সবাইকে স্বাগত জানাচ্ছি। আমি সবার কাছে কৃতজ্ঞতা জানাচ্ছি। আজকের এই অনুষ্ঠান সকলের সহযোগিতায় আয়োজন করা সম্ভব হয়েছে, বিশেষত সায়েন্টিফিক সাব কমিটি যে অক্লান্ত পরিশ্রম করেছে, আমি তাদের সবাইকে ধন্যবাদ জানাই। অগাস্ট বাঙালি জাতির জন্যে একটি শোকাবহ শোকের মাস। আমি শ্রদ্ধাভরে স্মরণ করছি বাঙালি জাতির সর্বকালের সর্বশ্রেষ্ঠ সন্তান, এদেশের প্রতিষ্ঠাতা জাতির জনক বঙ্গবন্ধু শেখ মুজিবকে আমি তার আত্মার এবং 15ই আগস্ট 1975-এ নিহত সকল শহীদের আত্মার মাগফিরাত কামনা করছি। I would like to thank every faculties, those who are coming from abroad, especially from USA. They have taken a lot of burden and they will stay here for another 3 days. It's our privilege. We are really happy. We are lucky enough that these type of quality faculties now among with us, and they will stay with us another 2-3 days, and they will teach us. We are really grateful to them, and I like to thank them because they have taken a lot of burden. In spite of their busy schedule, they make space for us, and we are really happy for this. Especially, I like to thank Professor Chaudhary. He is actually our teacher, mentor, and son of this soil. He is the man, never he says no, he always says yes in cases of Bangladesh perspective. Anytime, any sort, any program which we try to arrange and ask him to, or go to him for help, he helped us a lot, not for now, for long, at least 10-15 years. I like to thank him. Dr. Chandra Sundaram, Dr. Akhil Das, Dr. Charles Powell, all are renowned urologists. You have heard it from previous speaker. What I want to say, it is our privilege, and as they give us this privilege, that's why we are really, really grateful to him. On behalf of Bangladesh Urological Association Surgeons, I like to give again thanks, and I wish their happy stay in Bangladesh. আমি আশা করি আগামী 2 দিনের যে প্রোগ্রাম এখানে হবে সেটিতে আমাদের রেসিডেন্টবৃন্দ অংশগ্রহণ করবেন। আমাদের চিকিৎসক ইউরোলজিস্ট আমরা যারা আছি আমরা সবাই এই প্রোগ্রাম থেকে, এই সেমিনার থেকে উপকৃত হব, এবং সেই আশাবাদ ব্যক্ত করে সবাইকে ধন্যবাদ জানিয়ে আমি শেষ করছি। খোদা হাফেজ।
Thank you, Professor Kaji Rafiqul Abidin, sir. In this tragic month of August, I would like to recall our father of nation, Bangabandhu Sheikh Mujibur Rahman, who gave us the foundation to speak in this occasion and all the occasions as Bangladeshi. I would like to recall our great leader, father of nation, Bangabandhu Sheikh Mujibur Rahman. I would like to pay my heartfelt gratitude to ex-presidents of BAUS present here, Professor M.A. Salam sir, Professor A.K.M. Anwarul Islam sir, our President-elect, Professor Muhammad Habibur Rahman Dulal sir, our Secretary General-elect, Dr. Tawhid Muhammad Saiful Hussain, and all other distinguished delegates, faculties, participants, and especially residents for whom this program is designed. Now I would like to call upon Professor Ishtiaq Ahmed for vote of thanks, who is the co-chairman of scientific subcommittee. Professor Ishtiaq Ahmed.
Assalamu alaikum. President BAUS, Professor Rafiqul Abidin, chief guest of this inaugural session, Professor Kanak Kanti Borua, the Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, Professor Muhammad Chaudhary, who is a friend of Bangladesh, you all know. I would not elaborate more because he deserves more than that. Professor Jamanul Islam Bhuiya, the chairperson of the scientific subcommittee, Professor Shamim Ahmed, the Secretary General of BAUS, and Department Chairman of Urology, Bangabandhu Sheikh Mujib Medical University, Professor Khushidul Alam, and all the dignitaries in front of me. It's my privilege to make the vote of thanks to everyone. First of all, I would like to thank our chief guest, Professor Kanakkanti Borua. His presence has encouraged us. He is doing this for the last few years, and I'm sure he'll continue to encourage us in future also. Our heartfelt thanks to Professor Kanakkanti Borua. And next is to all the foreign dignitaries who is sitting in front of me, Professor Akil Dash, Dr. Sundaram, and Dr. Powell. They have taken a lot of trouble traveling a long way from Hyderabad last night, and I talked to them around 10:30 at night, and they were still on the road. And very thankful to them to be here and present all their deliberations to the residents and also to the delegates member of BAUS. So please accept our heartfelt thanks, all three of them. And also another one is Dr. Mutahar Ahmed. He has been here for the last few years, and I'm sure he'll be here because maybe he's on the traffic jam. And our thanks to him for being here. And also to the Department of Urology, who is the co-organizer of this program. And our thanks to Professor Khurshid Alam for his cooperation. And also to all the dignitaries and residents in front of me, because it's their program. So if they can gain something from this program, all the arrangements of the BAUS will be fruitful. So I encourage all the residents to make out full use of this program. And finally, to all the media persons and our scientific partner, UniHealth, UniMed, without them, nothing could have been possible. And also to, there are a few persons I should mention who are not here, about the American Urological Association members, with whom we had all the correspondences, like Lassie, Jessica, and Lori. So our thanks to them also, although they are not here. And finally, to everyone who is here, and please accept our heartfelt thanks to everybody. But finally, I must say that if I say thanks to Professor Chaudhary, it will be very less. So I'm not trying that, because he deserves more than that, because he's been coordinating and is the pioneer of all these lesson courses in the past, and I hope in future this will continue. Please, Professor Chaudhary, please continue your cooperation in future also. And finally, thanks to AU and BAUS for this arrangement, and hopefully everything will run fine in the next 3 days. Thank you all.
Thank you, sir. I would like to special thanks to our scientific partner, UniHealth and UniMed, for their endeavor they are doing for us. It's all from now. It's all from the inaugural session. I would like to say that the next programs will be conducted by Scientific Subcommittee of Bangladesh Association of Urological Surgeons under the guidance of Professor Jamanul Islam Bhuiya, who is the chairman of Scientific Subcommittee, Professor Ishtiaq Ahmed, who is the co-chairman of Scientific Subcommittee, and Dr. Shudip Dashgupta, who is the scientific secretary and scientific secretary. They will conduct the session. I would like to congratulate and give heartfelt thanks to all the participants, delegates, dignitaries, and special thanks to our honorable chief guest, Professor Vice Chancellor, our honorable Vice Chancellor, sir, Professor Kanakkanti Borua, sir, for his time he spent here. He is actually, I already said, he is our mentor, he is our guide, and he is everything for us. And I think he will continue this endeavor with us in the future. I would like to thank and congratulate all of you, and would like to end this session. Thank you all.
Respected members of respected residents, now we are going to start our sessions, and you all know the first session is on oncology, and the speaker is Dr. Chandru Sundaram, and his first talk on familial renal cell carcinoma. I request Dr. Sundaram to give his talk, and then he will talk on management of small renal mass, and he will give on role of biopsy, active surveillance, partial nephrectomy. These will be concluded, included in his lecture. And the last topic is the role of cytoreductive nephrectomy, the current status. Respected audience, our first speaker of AUA BAUS Relation 2019 is Dr. Chandru Sundaram.
So do you want me to catch up? We're half an hour behind. Do you want me to stop? When do you want me to catch up? Go half an hour earlier? When do you want me to finish?
Okay. Sir, you will talk
half an
these
hour
three.
earlier.
Yeah.
Do you want me to catch up? The time-wise?
No problem, sir. You can talk
Okay.
all the three.
Okay.
Okay, sir. We'll allocate the time later.
Okay.
So do you need any interval between these lectures?
No, I don't.
Okay, sir.
Good morning, and thank you all very much for this opportunity. Professor Abedin, Professor Shamim, Professor Ishtiaq Shamim, and Professor Buya. It's an honor and a privilege being here at BAUS Lessons in Urology. On behalf of the Board of Urology, the Board of the Directors of the American Urological Association, I can tell you that the AUA is delighted to partner with BAUS on this educational endeavor. From a personal standpoint, you all know, and a lot has been said about Dr. Chowdhury, Professor Chowdhury, that you all should very rightly be proud of. But I can tell you that the AUA is similarly very proud of him, and he's truly the best you can get at the AUA. So I am privileged to know him as a friend and have known him for quite a while. Now I'll get down to the purpose for which we are all here, and the three of us, I can speak for all the three of us faculty from the US, that we'll try to be as instructive as possible, but this is a great opportunity for us to learn from you as well. So we will keep this interactive, and after each talk or at the end of my session, we will certainly encourage interaction from the audience, from the residents, so that we can learn together. So my practice is mainly kidney cancer and minimally invasive and robotic kidney surgery, adrenal surgery, and some prostate cancer. That's what I do. I've been doing this for over 20 years. And I'll share with you my experiences with these pathologies. So I've been asked to speak about familial kidney cancer, and that will be my first task for the day. I have about an hour and a half before a tea break, so we'll end at 10 or 10:30 as requested, and I can certainly be stopped at any time, and I can make up time as well. So let's talk about familial kidney cancer. This is not something we see all the time, but the awareness of familial kidney cancer is important, because those few patients who do have kidney cancer with a genetic predisposition need to be identified and treated appropriately, not only for themselves, but for their family as well. It's about 5 to 8%. The AUA guidelines would suggest that anyone less than 46 years of age be investigated for genetic kidney cancer or familial kidney cancers. The median diagnosis of familial RCC is about 37 years compared to 64 general population, And if you have a sibling with kidney cancer, that increases the chance of developing the disease twofold. These are the various conditions that I will go through over the next few minutes. VHL is by far the most common of these. And for the residents, I think you need to just know these genes, which is the cause for these conditions. So I'm not going to mention these chromosomes, but you will need to know that for your exams. And the other conditions I will go through, and also the clinical correlates for each one of these. VHL is associated with clear cell renal cell carcinoma. So each familial RCC syndrome is associated with a specific cell type of kidney cancer, and you need to be aware of that. It is not very common and is an autosomal dominant. Certain other conditions are also associated with VHL, pheochromocytoma and renal cysts, which are of urologic concern, but it's important to interact with other specialties like the GI surgeons for pancreatic cysts and the ENT doctors for inner ear tumors. These are some of the pictures that you could see with in patients with VHL. A lot of these VHL patients that you see for kidney cancer are oftentimes associated with CNS tumors, in this case, hemangioblastomas, the base of skull, and here in the spine. They also are associated with ophthalmologists. In this case, in a retinal angioma. Rarely do you see epididymal cystadenomas, less than 1/4 of them, and this is obviously a urologic issue. What about cancers associated, kidney cancers associated with VHL? There's a 50% chance of them being diagnosed with kidney cancers, patients with VHL, usually in the 3rd to 5th decade, bilateral and multifocal. Early recognition is important, and the most common cause of mortality in these patients is RCC. What is the genetic problem that results in the VHL? This, again, for the exams, I think it's important. The VHL gene suppresses production of HIF alpha. And if this is suppressed, you get increase in these factors here. And that causes a lot of anomalies, which results in not only tumors, but also other conditions. So nephron sparing surgery is the gold standard for VHL. Partial nephrectomy should be performed for greater than 3 centimeter tumors. So the goal here is to observe tumors until they get to 3 centimeters in size, because typically these tumors are multifocal and bilateral. So if you go after every tumor that's 1 or 2 centimeters in size, you'll end up doing multiple partial nephrectomies and rendering them anephric before they need to be. So wait until the bottom line, and most of these, I'll tell you, give you the exceptions, but most of these familial kidney conditions, you observe these patients until they get to about 3 centimeters and then operate upon them. In those cases, you probably do need to do enucleation in order to conserve renal parenchyma. So I had a patient recently who went through multiple partial nephrectomies on each side, and finally we did bilateral nephrectomies, and the patient has now got a kidney transplant. So that's certainly possible. So ultimately that's what may happen, but you have to delay that eventuality as much as you can, and hopefully you will be able to preserve renal function. Like we said, multiple specialists can be involved, and therefore you should work in collaboration. In our institution, one of my colleagues runs a multidisciplinary clinic for familial renal cell carcinomas. That finishes with VHL. Now, hereditary papillary renal cell carcinoma is associated with papillary type 1 RCC. Type 1 is usually low grade. So remember, type 1 papillary is not very aggressive. Type 2 papillary is more aggressive. So in general, that's true. And therefore, with this cancer is associated with type 1. And so you should follow the same surgical principles like we said before, wait till 3 centimeters and then operate on these patients. They're autosomal dominant. What about hereditary leiomyomatosis, renal cell carcinoma? These are associated with cutaneous leiomyomas and uterine leiomyomas. And RCC is seen in 20%. And the difference with hereditary leiomyomatosis, renal cell carcinoma is that they are solitary and aggressive. So these, you do not follow the 3 centimeter rule. Take care of it even when it's much smaller. So this also, you should not do a clear enucleation like you would do with RCC associated with VHL. So this is a little different from what we just talked about. Bertok-Dubé is another interesting condition. It's associated with cutaneous lesions, but also with pulmonary cysts. From a surgical standpoint, when you're doing partial nephrectomies on this patient, they may develop pneumothorax. So it's important to collaborate with your anesthesiologist. Tell them that this patient has Bertok-Dubé. They may have renal pulmonary cysts. These cysts may rupture if you have high pressure ventilation, may cause pneumothorax. This is the lesions seen in Bertok-Dubé. And Bertok-Dubé is associated with an interesting renal tumor, oncocytoma and chromophobe, but oftentimes you get a hybrid, which means a hybrid of oncocytoma and chromophobe together, and therefore biopsying these patients, you may get an oncocytoma, but remember that it could be a chromophobe as well, and these need to be followed carefully. And again, these are also bilateral, multifocal, and wait for the 3 centimeter size before you operate, just like you would do with VHL. Again, succinate dehydrogenase renal cell carcinoma is aggressive, and you should not wait until it gets to 3 centimeters. So the two aggressive familial renal cell carcinomas are succinate dehydrogenase and the leiomyomatosis renal cell carcinoma. These are associated with pheochromocytoma, GIST syndrome, paragangliomas, carotid body tumors, and renal tumors. And these are aggressive, like I said, and you need to do a wide resection, not an enucleation. Tuberosclerosis, you probably see more frequently. These are not usually associated with renal cell carcinomas. They're usually associated with angiomyolipomas. Angiomyolipomas are easily recognizable on a CT scan with fat in it. So there'll be negative Hounsfield units. So if you see multiple AMLs in a patient, in a young patient, think of tuberosclerosis and have the patient checked out. They may have additional sequelae of tuberosclerosis, like mental retardation and so forth. But even if that does not happen, check them out for tuberosclerosis. Those are the lesions seen on the skin and the lungs with tuberosclerosis. What is interesting with tuberosclerosis is that the mTOR inhibitors can be used for the medical management of tuberous sclerosis. And recently, it has been FDA approved not only for renal angiomyolipomas, but also for partial onset seizures associated with tuberous sclerosis and giant-cell astrocytoma, which is CNS tumors. So this is, I think, very interesting, and you must know for your exams that AMLs, bilateral AMLs associated with tuberous sclerosis can be medically treated with mTOR inhibitors like everolimus and sirolimus. The response rate with this medical treatment with everolimus is 42% at 6 months. Response rate means decrease in size by about 50%. Genetic counseling is important in all these patients. I think it's important. And in summary, most of these tumors can be managed after they get to over the 3 centimeters in size. Surgical enucleation and nephron sparing approach is required. The two exceptions where they're aggressive are the hereditary leiomyomatosis and the succinate dehydrogenase renal cell carcinoma, and a multidisciplinary approach is essential. And this finishes my talk on familial renal cell carcinoma. This is just the board of directors of the EUA that are present recently. and I bring greetings from them. As has been said before, the AUA has multiple resources, and membership of the AUA allows all residents to avail those opportunities. When I was a resident, we would read Campbell's. Now, majority of our residents get their knowledge from the AUA University. So I think it's a big resource that all of us can use. Thank you all very much. So Professor Shamim, should I proceed with the next talk, or do you want questions or answers before? What do you say? I can do either one. Just proceed? Okay. So I've made up some 15 minutes, so I'll take a little longer time for the next talk, which is there. Yeah. Pardon? What? Yeah, I'm fine. Yeah. So my next talk is on management of renal masses, and I've tried to make this based on cases of mine that I've managed over the years. And with each case, I have some clinical objectives and teaching points, and we'll discuss teaching management issues associated with that case. So with renal cell carcinoma and renal masses in general, I think you have to be individualized. So when you see any patient with a renal mass, think about the tumor, things like nephrometry, which means is the mass endophytic or exophytic? Is the mass large or small? Is it polar? Is it central? All these things need to make a difference. There is also a nephrometry score. I haven't got those scores in my talk today, but look it up, and there are various methods to score these tumors, but RENAL nephrometry score is the most common score, so that involves tumor factors. Patient factors are very important. In the US, obesity is very widely prevalent, so that does make a difference. Not so here, but other conditions here like previous surgeries, hostile abdomens, spinal deformities, things like that can also be of concern even if obesity is not a problem. Also, risk for anesthesia is important. Things like comorbidities, age, life expectancy. Think about the risks and benefits of intervention versus no intervention. If the patient is elderly, is going to die of some other condition within 5 or 10 years, a small renal mass probably never needs to be operated upon. Very similar to low-risk prostate cancer. And finally, once you've decided the patient needs surgery, think about yourself, your experience, and the team and the hospital. I recently was talking about, I was told about patients who had gone abroad, had surgery, one of them died, and the other of them came back after a 42-unit blood transfusion. So that clearly was not a very wise thing to do, because they were not aware of their own capabilities and the capabilities of the institution. So things like that should not happen if all these factors are taken into account before you decide to proceed with surgery. So let's get to our first case and put all this together and plan our management. This is a 51-year-old gentleman with abdominal pain, 8 centimeter left upper pole renal mass. MRI confirms a solid renal mass, and then they did a PET CT scan. So you may ask why a PET CT scan was done. And a PET CT scan is not indicated, I repeat, not indicated for renal cell carcinoma typically. But lots of our oncologists in the US will get it done before they send the patient to us. So this is again a lesson of what should not be done for a typical patient with renal cell carcinoma. However, this was all done, so the diagnosis was a renal cell carcinoma. The patient was sent to me for a radical or a partial nephrectomy. So this was the CAT's MRI that was done, and those were the images. So heterogeneously enhancing, some necrosis in the middle. So what do you do next? So when I looked at this CT and MRI, there was this central scar, and we were also doing this study with the radiologists on sesame B scan. This is something new, and I would not say this should be done, but this is something that we did. So we said, let's check out the scan, sesame B scan. So this was a PET CT scan where you give them sesame B, which is usually used for the parathyroid. And if it lights up, that means it could be an oncocytoma. So it lit up very well. Again, this is not the standard of care. This is more investigational. But I just wanted to show you what the imaging modalities that are available more and more commonly with renal cell carcinoma. So then I obviously did not completely believe this scan since this was investigational. Did a biopsy. It came back as oncocytoma. So the lessons here are all big renal masses or small renal masses are not cancers, though majority of them are, number one. Number two, you should do a renal mass biopsy if you think that you're going to make a difference to this patient as far as management is concerned. In this patient, obviously we made a difference because we are not going to operate on this patient with a benign renal mass. So let's look at the AUA guidelines for renal mass biopsy. So let's talk about renal mass biopsy in general. When I was I was a resident, almost none of the patients had a renal mass biopsy unless we suspected a lymphoma, we suspected metastatic deposit in the renal cell carcinoma, or we suspected that this was an abscess or an inflammatory condition. That was the absolute indicators for doing a renal mass biopsy. However, that has changed. And in some places in the United States, and especially in Canada and Toronto, they biopsy every patient with a renal mass. And I probably biopsy maybe 30% of the patients with renal masses when I think it's going to make a difference. Why would it make a difference? If it was not cancer, I would not operate in someone who was old. If the patient is not a very healthy person, I'm not going to operate and take out a benign tumor and risk any other post-op complication. So these are or if you think the grade of the tumor would make a difference in an elderly patient, all this is important. So oftentimes the patients, even in America, come back and tell us, a biopsy will spread cancer, seeding, and so forth, and that's really not the case. Needle biopsy is very safe. There's 1% symptomatic complication and almost no risk of seeding. So the renal mass biopsy is fairly accurate. Sensitivity and specificity is over 90%. Non-diagnostic rate 14%, and that is even, and you can certainly get a repeat biopsy at that point. The grading is much more difficult. So if you are going to rely on the grade, then you don't be too happy. You cannot be too happy with the outcome from a renal mass biopsy. So they're 30 to 60% accurate for nuclear grade, and oftentimes it is underestimated. So these are the various series of renal mass biopsy. As you can see here, the complication rate is 1%. The diagnosis rate is over 80% in most cases. So they're all very good numbers to confirm that there's nothing wrong with doing a renal mass biopsy. However, having said that, all these series are patients, institutions where they have a good radiologist who is experienced at doing renal mass biopsy. So if you really want to get into this become a busy kidney surgeon, you need to have a good relationship with a radiologist who's capable not only of reading your x-rays, but also doing a good CT scan guided or ultrasound guided core needle biopsies. This was a scheme used by Dr. Wolf and his colleagues when he was at the University of Michigan about how they stratified patients with renal mass biopsies. In this case, they biopsied all renal masses. I'm not suggesting that this be done, by no means, but this is one of the techniques they used to see what the renal, what to do with these patients. And the only take-home message from this slide would be that less than 2 centimeter patients can be observed, and these very favorable histologies could be observed. Chromophobe, oncocytic neoplasms, grade 1. Grade 1s you rarely see on a biopsy, so that's not a big group of patients. But you could see oncocytomas or oncocytic neoplasms, and those can certainly be observed. And anyone with a larger size or with indeterminate or clear cancer should be operated upon. So what about active surveillance? This is a group from Toronto that just observed renal masses, and these were typically patients who were older and infirm. And they found that the local progression was seen only in 12% of the patients, metastasis only in 2 out of 178 patients, and the tumor growth was less than 0.2 centimeters per year. So it's fairly safe to observe the patient. The take-home message here is not all renal masses need to be operated, especially in older and high-risk patients. So you can safely observe them, just like you do with active surveillance with prostate cancer. But having said that, larger tumors, younger patients should all be operated upon. It's still a surgical disease, and you have the best chance of treating them when they are small and surgically amenable to treatment. Now, another case, this is a partial nephrectomy that was done in a patient with a mass in a transplant kidney. This patient, we have a big transplant program in our hospital. I take care of most of the urologic issues with the transplant population there. Left renal mass was seen in a transplant clinic, incidentally, 2 centimeters, renal nephrometry score of 9. And we did a biopsy of the renal mass in the transplant kidney, comes back as Furman grade 3 renal cell carcinoma, and they said it was clear cell on the biopsy. So I'll show you the CT scan. So this is the CT scan of the transplant tumor. So completely endophytic, you see no external deformation of the cortex, and it's about 2 centimeters in size. Right there is a renal mass. So what do? The transplant surgeon in our institution, I do a lot of the living donors, and I take care of all their polycystic kidneys and all that, but they do the actual transplantation. So the transplant surgeon was ready to take this kidney out, and I said, let's give it a chance and let's do a partial nephrectomy. And that's what we did. We did a robotic partial nephrectomy, put up urethral catheters, put them in a low lithotomy position with warm ischemia, clamped the iliac artery above and below the transplant anastomosis, and completed the transplant nephrectomy, transplant partial nephrectomy. It did take a long time. It was not an easy case. 100 cc blood loss, 15 minutes warm ischemia time. Patient went home on day 2. And the pathology was a RCC translocation type. These are the more aggressive, high-grade tumors. So I'm glad we surgically removed it rather than observing it, because they have a higher incidence of metastasis even when they are small in size. So this was done a couple of years ago, and I still follow this patient. He keeps his transplant kidney, and he is cancer-free. So the lessons learned in this was nephron sparing surgery should be considered for all T1 tumors. T1A is less than 4 centimeters. T1B is less than 7 centimeters. So definitely less than 4 centimeters. They should all be considered for nephron sparing surgery. Some T2 tumors, like hanging off the lower pole or the upper pole of the kidney, if it's technically possible, go ahead and do a partial nephrectomy. But do not take out the whole kidney. I think this is important for urologists to know, because it's easier to take the whole kidney out. Don't remove it. preserve nephrons if it's a small renal mass. What about warm ischemia? There's lots of argument, debate, papers written on warm ischemia and cold ischemia and how it affects the kidney function. And the bottom line is, it really doesn't matter if the warm ischemia time is less than 20 minutes in the vast majority of the patients. So the patient has a solitary kidney with chronic kidney disease, then maybe you want to try cold ischemia. But I think cold ischemia is most useful if it's a very complex partial nephrectomy, you're going to do it open, and you think the warm ischemia time is going to be more than 20 or 30 minutes. Then I think cold ischemia is very useful. But warm ischemia time of 30 minutes, of 20 or 30 minutes is better than doing a radical nephrectomy. So just because it's a difficult partial nephrectomy, don't reflexly just take the kidney out. Try to do a partial nephrectomy, and if you can do it with a warm ischemia time of less than 20 minutes, that would be perfect. And if you're doing it open, do cold ischemia, you can even take a little longer time. And as far as approach is concerned, open versus laparoscopic versus robotic, I think it all depends on the surgeon, and be honest with yourself. When I was trained doing open surgery, then started doing laparoscopic surgery, and now I do robotic and laparoscopic and open surgery right now. And so it should all depend on your own experience and the people around you. So let's switch gears now. We'll talk a little bit more about partial nephrectomies, but let's switch gears and talk about cryoablation. So this patient was 65 years old, solid enhancing mass, multiple comorbidities, had coronary artery stents placed on multiple medications as seen there, including Plavix, which is an antiplatelet agent. So this was the tumor in the pelvic kidney, 3 centimeters in size. So like I said before, you should do a partial nephrectomy even though this is a pelvic kidney, and it may not be the easiest partial nephrectomy. So that's what we did. So that's the tumor. So we did a robotic right partial nephrectomy in the pelvic kidney, and this was the immediate post-op picture. The tumor is gone, and the